and good afternoon, everyone, for inviting me for this wonderful webinar. So, over last 2 years, I will say we saw a lot of things, and the way COVID has changed our life, our perspective towards life, our understanding. I think all of us, it's a lifetime experience. We will remember it, we'll share it probably with our children, grandchildren, the stories we had, the time we had during these 2 years. So what's long COVID? So we'll just go through this, why it became important for us to discuss. We had 3 waves in India, in other countries even more than that. And we had at least 2, or some of us have received at least 3 vaccination. So after 3 waves, a lot of patients are there who had COVID in the past. Number of us ourselves had COVID in the past, our family members had. So we have a personal experience as well as physician. I think every doctor in India treated COVID patients in last 2 years. So we will go through it under these headings. We will learn what is long COVID and how many patients develop persistent respiratory symptoms after COVID, and who are the guys who are at risk, so that we can identify them. We know which patients can develop it, so that we can follow easily. And then we look into that, what are the functional respiratory function, pulmonary function abnormalities, what are the abnormalities in X-rays and CTs. Probably we got CT scan just done more in India in last 2 years than what were done over last 10 years. And number of time patient brings their own CT scan and show us, so it's important to discuss that. And then we will see how to evaluate patients who come back with persistent cough or breathlessness after having COVID, and then how to manage these symptoms in long COVID. So briefly, we'll just go through this 2-year journey. So December 9, 2019, it started when we came to know about this COVID-19 virus from China, and then by Feb, we started knowing that it's spreading, and WHO declared pandemic. So the initial reports, when in India also first wave happened, and this is the one report from Riyadh, Saudi Arabia, when they published, the initial report showed that those patients, when you follow them, number of them allowed more than half develop persistent symptoms, shortness of breath, cough, and fatigue, most common. And they keep coming, and the imaging also shows shadows over there. So we lot of discussion about it, and we had some experience with the initial SARS viruses. We knew those patients come back with the CT abnormalities, sometimes fibrosis. So there was a huge worry at that time among all the pulmonary physicians, or I will say all the physicians, that probably we are going to see a lot of ILD cases now after this COVID. So you might have seen papers like this where a tsunami that will follow the earthquake. So we were all worried at that time. And this is similar report from China, where around 1,700 patients were followed up in 2020 during the first or second wave. They followed them up, found the similar symptoms: fatigue, sleep difficulties, anxiety, depression. They also did CT scan and PFT and found this PFT DLC was decreasing, 6-minute walk test also decreased. They also found abnormal chest manifestations. They also looked deeply into it and said that those who are more severely ill during their hospital stay, they had more impaired pulmonary diffusion capacity, impairedness, and they had more chest shadows in the lung CT scan when they come on follow-up. And that was the reason we were worried about it. However, as the pandemic continued, we started following up patients continuously at 3, 6, and 12 months. Further report came, and this is a 12-month follow-up report from Italy. As the China paper was showing, those patients who are having severe disease, so these patients were all having acute respiratory failure. They were treated with mechanical ventilation. So as maximum disease they could have had with COVID happened, those patients were followed up. 116 patients, as it is from 2020 only, and half of them survived. But those who survived, when they followed them up for next 12 months, they found actually they had good functional recovery. They had some symptoms at 3 months, but as they followed them further, more than 80% reported no difficulties in usual activity. Dyspnea also improved, and though anxiety, depression were there, and CT scan abnormality were also followed up, and they realized that those CT scan abnormalities also resolved, and fibrotic changes were found only in 4 out of that 61 patients. So this report indicates us that as we increase our follow-up time, what we are fearing that there will be a lot of ILD cases. COVID didn't turn out in that way. Most of the shadows in the scan resolve. So that was the background. So now let's learn what is long COVID. So long COVID, various names have been given: post-COVID syndrome, long COVID. So long COVID is the symptoms of sign persisting or relapsing for more than 12 weeks or 3 months after an acute COVID-19 diagnosis, when we have ruled out all the alternative explanations. Because we know during COVID times, when it started in first wave and second wave, so many therapies were given, and sometimes iatrogenic injuries also happened. In India, we knew there was also almost an epidemic of mucor. So when the symptoms are persisting after COVID, we should always rule out the alternative explanation. There could be mucor, could be TB, sometimes a hidden malignancy there. Once you rule out, then it becomes long COVID. WHO names the same condition by post-COVID-19 condition. That is also after 12 weeks, same duration, but they said duration should be at least 2 months for the symptoms to persist. And CD calls it around, starts calling it around 4 weeks after acute COVID. That's the duration by CDC. How many patients complains of long COVID or have symptoms after 3 months? Around 20 to 40% of them, those patients, they experience some one or other symptoms of long COVID. And there is one more entity we should look into called post-acute COVID. This happens between 4 and 12 weeks. Just before, from 12 weeks onward, we call it long COVID. Before that, after COVID, between 1 and 3 months, if there are symptoms and patients are having persistent symptoms of breathlessness and they are coming back, we must rule out diagnoses like myocarditis, venous thromboembolism, thyroiditis. These are all happens because of the COVID-19. Lot of publications happened over the past 2 years, and number of publications are so many from each country that it is sometimes when you go through the papers, it is difficult to analyze all of them or read them. However, good thing is a lot of meta-analysis and systemic reviews also have been done. And now at least we have Indian guidelines on long COVID. We have European guidelines. We have nice guidelines from UK. So what we will do is we'll go through the guidelines because and the systemic reviews, because they already reviewed the evidence available or literature which has been published. So these are our Indian guidelines were published by Director General of Health Sciences and Ministry of Health, and these are called National Comprehensive Guidelines. According to them, among the hospitalized patients, not in all patients of mild to moderate COVID, but patients who require hospitalization, among them, around 80% of patients may report some breathlessness at the end of 3 months also. And but if we look deeply into that, we will realize that breathlessness is quite severe, means MMRC 2 or more. That will not be that much. So some breathlessness, but not very severe. And if we look at the imaging, there may be some imaging abnormalities in up to 80% of patients if we look at their CT thorax done at 3 months interval. And if we do the pulmonary function test to assess the lung function, around 50 to 60% of cases may show some PFT abnormalities. What are the symptoms? If we go by symptoms, most common symptom is fatigue, and then body ache, myalgia, musculoskeletal pain, anosmia, dysgeusia also troubled a lot of people. And there was a word used like brain fog or cognitive impairment, because people don't feel okay or as usual as they were before COVID, and sleep disturbances. And decreased quality of life was also noted in more than half of the patient in a systemic review. So we can look at the long COVID. It affects our quality of life in multiple ways and affect multiple organs. As far as chest symptoms are concerned, dyspnea could be found in just less than half of the patient, 24 to 40%. Cough, they can present with cough in 7 to 30% of patients, and some of the patients may also complain of chest pain. What's the pathophysiology? Why is it happening? There could be multiple reasons. One can be damage to the respiratory symptoms by the virus itself. And then virus used to initiate cytokine storm. We learned that also. So that also causes damage to the lung. And then there are multiple comorbidities which patient had, and that's why they developed a more severe COVID and underwent cytokine storm. And the side effect of the drug therapy, as well, I was saying, a lot of patients received high dose of steroids, developed mucor, and so many other things. And similarly, there were side effects of drugs which they received. If you look further deeply into that, then what could be the pathophysiological mechanism is largely unknown, but it it is positive immune dysregulation and response and neurotropism of SARS virus. And sometimes the most common symptom and myalgia, it matches with the post-intensive care syndrome, because most of the time long COVID symptoms are happening in patients who had more severe COVID-19 disease, required HDO and ICU care. If you look at the pulmonary abnormalities in long COVID, what happened, there could be a diffuse lung disease, which could be inflammatory or fibrotic, and then respiratory muscle weakness, especially in the patients who receive prolonged mechanical ventilation. And then pulmonary thromboembolism also was common in long COVID and mechanically ventilated patients. So it's a symptom. And then pulmonary infections, secretly, including mycosis, because COVID itself was predisposing to other pathogenic infections, and then most of those patients who are too sick and hypoxic required steroid medications, which made them prone for pulmonary infections. Can we identify the red flags, or can we find out which patients are going to have more symptoms in long COVID, or who are going to come back to us after 3 months? The meta-analysis shows that patients who had severe acute COVID, they are more prone to develop symptoms of long COVID. Similarly, female gender, they have twofold of developing symptoms and coming back to the hospital with long COVID symptoms. Advanced age, obesity, smoker, presence of comorbidities like diabetes, hypertension, coronary artery disease also make the people more at risk of persistent symptoms. Pre-existing lung disease like COPD, asthma, ILD, we all knew those patients were more prone to have more severe COVID. And similarly, patients who were already on LTOT, long-term oxygen therapy, or who were already having hypoxia, those patients were more prone to develop more severe COVID, and more severe COVID lead to sometimes long. How to assess the patients with long COVID? Actually, patients of mild to moderate COVID-19 disease, or who had even severe disease but improved symptomatically, they do not require much follow-up. So who require evaluation are the patients who are symptomatic at 3 months interval, fulfilling the criteria of long COVID. At the same time, we should, as I said, we should not always like malignancy, thromboembolism, myocarditis, because which may be there and we may not have noted them during COVID. And thromboembolism happened because of COVID, myocarditis also. If they are there, we should rule them out, this condition, and then take it as long COVID. And obviously manage the comorbidities of diabetes, hypertension, or any like bronchial asthma or COPD. Most of common and cough, and they require management, but immediate management, or we should start assessing them, are when there is severe dyspnea like MMRC grade 3 or 4. There is hypoxia, 6-minute walk test showing again desaturation less than 90%, chest X-ray showing abnormalities and explaining these conditions, when we should refer those patients to the specialist or pulmonologist for extensive workup, something like pulmonary function test, including spirometry, arterial blood gas. A CT scan of thorax should be done depending on the suspicion whether HRCT thorax, or if we are suspecting pulmonary embolism, then CT pulmonary angio. Now, if you look at the PFT or patients of long COVID, usual PFT pattern is restrictive, thereby decrease in FVC and total lung capacity. Common abnormality noted in post-COVID cases were decrease in DLCO, but it was also noted that gradually it improves. So initially at 3 months, patients have decrease in DLCO, but when we follow up, this is also noted that it improves. However, in severely critically ill acute COVID-19 patients who had very cycle ventilation, sometimes when you follow them up to 9 and 12 months, in some patients, DLCO remain low up to 22, and sometimes total lung capacity may also be found low. While in mild disease, DLCO may be found low in few patients. Usually it is the severe disease which patients develop more symptoms and more normality and decay. If you look at the chest imaging, chest X-ray may show reticular or ground loss opacities in up to 12% of cases on follow-up. It doesn't totally correlate with the post-COVID symptoms. Sometimes patient may not have symptoms and better, but chest X-ray may show some fibrotic scars. We all have seen our patients of tuberculosis also. Sometimes they may show shadows without any symptoms. So it can happen after COVID also. And if the patients are symptomatic, then chest X-ray can be done at 12 weeks interval. So not all patients require chest X-ray actually. If we review the CT thorax for these long COVID patients, there could be ground glass opacities, there can be reticular opacities, there could be well-established fibrosis also. It especially happens in patients who are old age and or who had more severe or critically ill COVID-19 disease. However, the good thing on follow-up we have learned is that if you keep following them over 1 year, it shows that the decrease in opacities from 55% cases to 39% cases. So there is an evidence now of after following patients over 1 year or more, we know that these opacities decrease gradually. And so CT thorax can be ordered only in patients who are having dyspnea or abnormal PFT, and we want to know the reason for that. Otherwise, for every patient coming at 3 months follow-up and not having symptoms or PFT is not too bad, doesn't require a CT thorax. How to treat persistent lung symptoms? Particular syndromes like organizing pneumonia, if the patient is symptomatic and CT scan shows organizing pneumonia, sometimes at discharge also we realize that, then those patients receive some low dose steroids for 3 weeks and all, and they improved in symptoms. However, this was also noted that studies have shown that similar patients having similar shadows and they were not giving steroids, just followed up, they also showed significant spontaneous recovery in all parameters. Therefore, the question whether our patients who are too sick or getting discharged from ICU or at 3 months with lung shadow, shall we give steroids? There is enough evidence now that patients improve and they do not require steroids. As far as antifibrotic is concerned, it's a very hot topic and a lot of questions I received for this webinar also, that role. However, studies are being done, trials are going on, and I will say as we started in 2020 and at the start of 21, we were worried about the tsunami of ILD, and also there was a lot of interest in nintedanib and pirfenidone. We wanted to prevent our patients from developing more fibrosis or ILD. However, we also noted, as the previous slide shows, that lung shadows, fibrosis, usually they do not progress at least. So till now, there is no conclusive evidence that our patients require nintedanib or pirfenidone for these shadows. However, trials are still going on and results are awaited. I am hoping in 2022, trials even from India are going to get published and we will learn more about it. Cough is a common symptom and how to treat it. Most of the time in long COVID, cough required just a symptomatic treatment like cough suppressant, like dextromethorphan. However, I will point it out that if the patient is coming with the symptoms and if we have done a simple test like spirometry and it shows obstructive ventilatory defect, then those patients may still benefit with the inhaled bronchodilator or ICS. Or I will say if the patients have an history of asthma and in the past and was overlooked or not treated, and after COVID we are realizing it better to treat them with the inhaled bronchodilators and ICS. Patients improve. Other cause for cough can be gastroesophageal reflux disease, which should be treated with the proton pump inhibitors. A lot of patient complaints of sore throat, and that's why they keep coughing. A warm water gargle or lozenges can help in those patients. However, if the patients are having too much symptoms and cough and it is troubling them, gabapentin and pregabalin also offer some help. Dyspnea is another common symptoms where in long COVID with which patient presents with a pulmonary medicine OPD. And as I said in the previous slides, most of the time these lung shadows, diffusion capacity abnormalities, they improve. So the most of the time patient requires more breathing exercise and walking daily. It helps. Pulmonary rehab we will discuss in the subsequent slides because that is the main treatment for dyspnea in long COVID. However, if the patient is having hypoxia, they can be given oxygen therapy. And as in the previous slides I showed, we can evaluate them with the complete PFT and scan, rule out thromboembolic phenomena and other reasons why they are hypoxic still. And if the PFT is showing an obstructive ventilatory defect, surely they should be treated for that with the inhaled bronchodilator and maybe ICS. This is an important slide because it's almost the mainstay of treatment in long COVID, pulmonary rehabilitation. And if you see the meta-analysis and systemic review, pulmonary rehab showed a remarkable effect in long COVID symptoms. It improves the walking distance, 6-minute walk test, improve the quality of life, improve the feeling of dyspnea, and also there was improvement in lung function, and it improved the anxiety score as well. So it has multifaceted effect and improvement in most of the symptoms which we see in our patients with long COVID. When to start the pulmonary rehab, when to refer them for occupational therapist or PMR department, or when to start refer them to respiratory therapist, I will say as soon as possible. If you look at the recommendation of British Society of Rehabilitation Medicine, they say rehab starts at the time of patient admission for COVID-19. It continues through the hospitalization, and then after discharge also it continues. So that's the importance of pulmonary rehab in long COVID. Change of smell, change of taste are annoying symptoms, and our patients often complain them when they come to the hospital with the breathlessness or cough or any long COVID symptoms. These are the common associated symptoms, and they are really annoying and troublesome. However, a concise statement by clinical olfactory working group says that there can be given some olfactory training with the help of ENT, may be helpful. Smoking cessation also helps in such cases. Steroids, systemic as well as nasal, are theophylline, sodium citrate, all were tried, but our role is all controversial. And it's important to counsel the patient. Physician should discuss it and reassure the patient that very soon spontaneous recovery comes. Sometimes these symptoms persist for some time, I agree, but still follow-up reports reveal that patients improve. Fatigue is another troublesome symptoms which patients feel after COVID and continue to feel over weeks and sometimes months. There can be clinical overlaps with long COVID and post-viral fatigue syndrome or chronic fatigue syndrome. And studies are heterogeneous, data is limited. Exact cause of this we are still have to find out. And however, like cognitive behavioral therapies, they help. Pulmonary rehab surely helps, as our previous slide shows. So graded exercise therapy, counseling, it will help. A drug, rintatolimod, has also been tried. It is just an immunomodulator. So I will conclude with that long COVID is a reality. We all know, we have seen patients. However, what we have to look into that patients who are having risk factors for long COVID, we should follow them carefully. We should rule out alternative diagnosis. We shouldn't miss the diagnosis of TB, malignancy, or mucor under the umbrella of long COVID, thinking this is just a long COVID and symptoms are persisting. Those diagnoses must not be missed. So we should look carefully in the images. and patient history and examination. And PFT and HRCT can be abnormal at 3 months follow-up when patient comes, and sometimes they have done the test or they have already got a CT scan done. But we can reassure them that usually these abnormalities improve over time. And pulmonary rehabilitation really helps, and we should help our patients by enrolling them in the rehab program. Treatment of lung diseases like asthma, COPD, ILD should not be changed or should not be stopped because of COVID, but we should continue. Uh, Inhaled steroids or bronchodilators all are allowed during COVID time, and even during acute COVID illness. Only for ILD, it was recommended to reduce the steroid dose to the minimum. Otherwise, patients who are having lung diseases and asthma, COPD should be appropriately treated. So I agree, it was a long road over 2 years or more, but we learned a lot. We have to go a long way, but I'm sure we have started seeing at least some progress in that. Coming months and years, we learn more and probably treat our patients in much more better way. Thank you very much.
Thank you, Dr. James. And this brings us to the questions. Before I take up the questions from our live audience, there are questions which have been posted by some of our participants during the registration process. So I'll start from there. And since you started with the fibrosis, lung fibrosis, so my first question is post-COVID fibrosis reversible? And second part of the same question, how to prevent post-COVID lung fibrosis?
Yeah, I think it's a very important and pertinent question, and all of us struggle with that question, that what happened, what we are seeing at the time of discharge or after 4 weeks when the CT scan done somewhere and patient came back and saying this much opacity is in the lung. Long-term follow-ups, as I said during the presentation, after 6 months, 9 and 12 months, showed that most of these opacities gradually start decreasing. And physiologically also patient improves in PFT. So now we have quite a bit of promising data that they improve and do not progress further. And do not progress further is a more important thing that we learned over the last 1 year or 1.5 years, because we were thinking that once these shadows are there, they are going to either progress or they're going to persist, then how we are going to deal with it. So they do not progress, most of the time they regress. How to prevent? I'll say when COVID started, we were not knowing how to treat, and a lot of things were thrown over there. And we knew that we also treated patients with medications which were probably overdosed steroid, and we saw the effect of that. And Mucor was a reality in India. So I will say over last 2 years now, COVID treatment has become quite simplified, and there is a living guidelines by WHO. We should follow that. So if we follow the guideline and keep the treatment to the minimum which is required, suppose steroid dose, so minimum low dose steroid only are needed during acute COVID, that also in patients who are having hypoxia. So as long as we control our hands and do not overtreat and drug side effect doesn't come, complication doesn't happen, then and prompt treatment for COVID so that it doesn't progress much. Now we also have antivirals which can stop the progress of COVID disease, and as well as we have antibodies treatment which prevents the progression of disease. Both these are important development over last 9 months, I will say. So when the patients who are having risk factor and when they develop RT-PCR positive and comes with a symptom, the earlier you start these therapies, the better, so that these patients do not require hospitalization, do not become sick. And we saw the presentation, those patients who are sick only develop more lung shadows. That's how we can prevent.
Taking from there, you have mentioned about follow-up, 6-month follow-up and 12-month follow-up. So Dr. Fatima from Pune, she wants to clarify, does that mean follow-up with regard to medication? That means, does it mean on medication for a year or a 6 months?
Most of the time, I think as we follow the patients, now we learn that most of them improve spontaneously. They do not require much treatment as such for post-COVID or long COVID symptoms. Their comorbidities of blood pressure, diabetes, cardiac or renal disease or lung disease like hypertension, COPD or asthma should be treated. But otherwise, for long COVID, they do not require much treatment. Pulmonary rehab is an important thing, but doesn't require much medication over there. So I won't say they are a follow-up on the treatment actually, but we are following them up just to, one, to reassure them as well as ourselves that our patient is improving over the time and not developing any other disease which could be missed during this time, because we know that sometimes tuberculosis, other things can be there. So for that reason, we are following.
Thank you. So we have a question from Colombo, Dr. Kalatunga. He is asking, what are the early interventions that should be taken to minimize long COVID?
Yeah, I think as the first question was going, we said long COVID is happening most of the time in patients who are developing severe COVID-19 illness or requiring HDU admission or hypoxia, mechanical ventilation. All those things now can be prevented with the help of newer antivirals, which are available now. And there are antibody therapies are also available, which prevents the disease progression from mild or asymptomatic COVID or mild to moderate or severe disease. I think that's the step we should take and prevent it there. Second important thing we learned over last 2 years is with the 2 doses of our vaccination, patient can develop infection with COVID, but usually this vaccination prevents the progression of disease to severe. So vaccination is another important thing in our armament now, and we should promote it to our patients as much as possible. That's the way to go.
So my next question is, you have mentioned about the memory loss, about the cognitive impairment. So the question is there memory loss included in the long COVID? From Bagura, Dr. Moshami.
Yeah, I think those symptoms are also included in long COVID. It happens, and they said brain fog and different names were given to it. It happens, and those of us who had COVID, we, as a physician also, I think we experience that what our patient is saying or meaning by saying that I feel like I don't feel normal as usual earlier. It's true, it happens, but the thing is it improves also, does not require as such active management, and if it is progressing, then only we have to look into or take a neurological advice.
So there are a couple of questions which I have put together, and it is asking about the antifibrotic. So the main question is from Dr. Partha from Kolkata, and he's asking, is there any documented, though you have mentioned, but I think just to say we can repeat, is there any documented role of antifibrotic in COVID-induced fibrosis? And also, if you can focus on antifibrotic a bit more, that will be helpful.
Yeah, I mean, the thing is, most of the pulmonologists were interested in knowing that, and everybody treated. I will not say that it was not given because worries were too much. And when there are shadows in the lung and we are thinking it is, we can prevent it and drug is not causing much side effect, patient received. However, this was the situation in, I will say, end of 2020 or maybe mid of 2021 after the second wave. But after the second wave, when the patients started coming back, and most of us realized that there are patients who don't come back. They come back later, 6 months also. And we suddenly were very surprised seeing that this patient was so sick and he was in mechanical ventilated and all discharged. We were worried about him. He missed the follow-up at 3 months. 6 months he comes, I'm all right. So we have sufficient data now that at least the disease progression doesn't happen. Most of the time they improve. The lung shadow, CT scan also improve, PFT also improve, patient also improve. So as such now at present, I will say anytime we give a drug, we see the risk and benefit ratio. Earlier we were worried about COVID and persistent fibrosis. So patients received antifibrotic, whether pirfenidone or the nintedanib. But any drug or these two drugs also have their own set of side effects. So we should weigh it carefully. And now at present, I will say the side effects, though not too many for both that medication, but still now the side effects will be a little bit more when we're treating regularly for many months than the benefit. Patients can be observed. And then if there's a persistence or something you think that it is there, or there's studies come up, which are going to come up, I'm hoping in next 6 months more, we will be more wiser to know when to give these antifibrotic therapies.
Our next question is from Dr. Anuja Sinha from Jamshedpur, and the question is, after COVID, throat irritation is still there, and I'm diabetic, also afraid about this sleep apnea. Can you please clarify?
Yeah, I mean, all of us were locked inside homes. We stopped going outside, stopped all exercise, playing, everything stopped. And probably we were anxious. We ate also more, though lockdown was there, but still, I think all of us gained weight. So that is a truth. And most of the people, I think, gain weight. And if we are in the upper band of the weight and BMI, and if there was history of snoring, yes, OSA is a reality. So it's kind of, they all come together and we had it. And so if OSA, two things are there. One is sore throat. So I will say the warm water gargle and all, it helps. So try that one. And if we are having persistent symptoms, we should not overlook presence of hidden presence of gastroesophageal reflux disease. Sometimes that causes this symptom. So we should treat that if it is there. We can do a little bit of change in our lifestyle. If you're sleeping at 9, we can finish our dinner by 7. Even that helps, because when we eat and sleep, reflux happens. If we have asthma or allergic rhinitis and we are using an steroid inhaler or nasal spray, sometimes that also stays in the throat and causes all this. So anytime you're using your inhaler, please take water or warm water, gargle and spit out. So that takes out the inhaler. If you use your inhaler with a spacer, that will also decrease the deposition of steroids in the back of your throat. Now the second part, OSA, if we are thinking that there is snoring, there is a daytime sleepiness or tiredness, mornings are not that refreshing, I will say OSA is a hidden disease causing a lot of other problems. Good to undergo a sleep study. That will settle.
Our next question is from Kathmandu, Dr. Nirmal. How long it generally takes time to return of the normal smell?
Smell, usually I will say 6 to 12 weeks, it should settle down, but I totally agree. And that we receive patients where it is persisting for 3 months and more. But still in those patients also is gradually settles down.
We have a question, Dr. Shah Jahan, and he wants to know your experience and opinion on antifibrotic nintedanib in COVID-related lung fibrosis.
Shahjaji, what happened is that I understand how your question, that patients received nintedanib by the chest physicians or other physicians and they improved. So we had an idea that drug is working, it is helping in our post-COVID fibrosis patients when they come at the review of 6 weeks or 3 months sometime. But at the same time, our own patients who didn't come back for review, and publications show that other patients, similar lung shadow in the scan, similar symptomatology, who did not take nintedanib also improved. So now we know that without that medication also patients have improved. That's the reason.
So I think a lot of questions, especially on physiotherapy, breathing exercise, and pulmonary rehabilitation. So we'd like to have your views on those and some more details besides what you have shared during the session.
Yeah, so pulmonary rehab is an important component. I will say, as already enumerated by Dr. Simi, that breathing exercise is one important component. So I will say, instead of going into too complicated breathing exercise, if you are doing some breathing exercise, some yoga at home, I'll encourage, please tell your patient to keep doing that, because it helps. If the patient is already doing, encourage them to do more. Any breathing exercise helps you. And otherwise, the simple diaphragmatic breathing exercises and all, they surely help. So those things can be taught to the patient. Just take 5-10 minutes from clinician side, or if we have a nurse educator or somebody or respiratory therapist, they can teach them. And a little bit of physical activity also helps. So basic small, like start walking every day, go for a 10-minute walk, gradually increase it to 15-20, and try to attain at least 30-minute walk any time of the day. That also makes a big difference. If they can do more and reach out to the rehab program, enroll themselves, do some rehab activity and muscle strengthening exercises, all the more better. So it helps in that case.
Dr. James, you have mentioned about walking, 30 minutes of walking. What will be your opinion for the people who are in northern India, where the pollution is also a major problem? So what time of a day should be chosen for a walk?
Yeah, that's a difficult question actually. So when it is winters and it is too cold, then we say please don't go for walk in the morning time, because it is settling, that pollution and all particles are settling down and all. So those issues are there. I will say keep an eye on your city, especially I think if you're asking from Delhi and some metro where it is too much. Keep an eye on the air pollution. Be careful because if it is outside, it is more polluted than your inside house. Maybe it is difficult at that time. And during COVID times, actually, we experienced better environment. So those days, though, if the lockdown is not there and it is allowed, actually, we were more safer to go outside than these days now. But as much as possible, I'll say keep an eye on the outside environment and see if we can do that, or we can join some gym nearby and can be there.
Thank you. And I think there are again 2, 3 questions which I'm clubbing together. Though you have already spoken, but how to manage patients with asthma and COPD with long COVID? Again, there's a question.
Yeah, that's a good question, I think, and we should not overlook these two diseases because sometimes we attribute those symptoms of cough or breathlessness or tiredness to the long COVID and say this is because of that. Anyway, you will improve. But if our patient has a proven COPD or asthma, we must treat them with the correct treatment and optimize the treatment for asthma and COPD because those patients were already prone to have more COVID disease. And now, as the disease progresses or they had a difficult COVID, they have more symptoms. But both the diseases can be treated, can be controlled, and patient can have a better quality of life. So I think those proven diseases must be treated and treatment. We can optimize them with the inhalers.
We have next question from Dr. Darvi, Mumbai. Can you talk about the impact of long COVID in sports people? And is there any data which is available?
I do not have, honestly speaking, on sports people separately. I haven't seen as such. I cannot tell you. Whatever the generalized data was there, I discussed. I think it affect because we are not active, and if they had COVID, there are a feeling of tiredness and other things. I can only tell you that with the resumption of activity, we can resume their strength, and probably we can play as well. Lot of sport personnel developed COVID, but now they are back in the game.
Okay, we have a question from Ahmedabad, Dr. Shivang. What management is advocated for allergic rhinitis post-COVID?
Allergic rhinitis, the main treatment is inhaled corticosteroids, and so a nasal corticosteroid spray should be given to the patients. We can add montelukast or H1 blockers as well for the symptom relief. But I think the mainstay of treatment is corticosteroids, which should be given in the lower dose as a nasal spray.
Again, there's a question from Sri Lanka, and the question is there any table to assess the severity of severe attack of corona, like curve 65 or something?
There was, I think, it was given by Indian guideline also, as well as WHO. We divide the mild, moderate COVID. So we see the symptoms, we see the oxygenation, we see the respiratory rate and all, and then we divide. So yes, they are available. If you Google by either by ICMR guideline in India for COVID or WHO guideline, you will get that classification. It's beautifully classified so that we know which patients will stay home and which require hospital admission.
The next question is role of oral steroids and any experience, your experience of any particular drug?
Oral steroids are for a long COVID, they are surely not needed. I will say during COVID also very low dose steroid only are needed. So as far as the reliance on steroid was concerned, I think with that mucor epidemic which happened only in our country, if we can be more and more cautious about it, the better. So as much as less we can use it and optimum doses, the better.
That's it. I think I have asked a lot of questions and we have spent good amount of time in question answers. There's a last question from Dr. Shabnam, Srinagar. Some of the patients say that after the use of steroids during COVID, they feel more craving for smoking. Is there any relation between the two things?
I'm not sure about this. I haven't come across that because they use steroid, they are craving for smoking. But I think the environment around us, the way COVID happened and the way we develop symptoms after COVID and this brain fog and other things, I'm sure if we had a habit of smoking, we may feel like that probably something which can give us a kind of activity or feeling of more active. So people may be smoking thinking that may give them some relief. But I hope that COVID didn't increase the smoking. I do not have data as such.
Thank you. And I think this brings to the end. And before we end, if Dr. James, if I can ask you just 4, bullet points you want all our participants to remember before we sign off.
Sure. I will say long COVID is a reality we saw, and as some questions were asked, how to prevent it. So that's important. Find out the risk patients with identify the patient with risk factor, higher in age, comorbidities, lung disease, and all. And make sure that our patients receive 2 doses of vaccine or 3 doses of vaccine if possible. If somebody develop it, try to treat them with a newer antiviral or antibody treatment so that COVID doesn't progress. In that way, we can prevent severe disease, and probably we'll see less cases of long COVID. However, those patients who are coming back with long COVID because of that second wave or third wave, we should remember that we have enough data now that we know that they improve. So pulmonary rehab may play a major role over there to help our patients.
Thank you so much. And it was wonderful to have you again. Thank you so much. And before we conclude, I'd like to remind everyone to please share your feedback with the link which will be provided to you. Do remember to follow us on LinkedIn and Facebook pages. Our handle is @BMJ India. And our next webinar is scheduled for 25th of March from 3 to 4. And the topic is management of type 2 diabetes mellitus, and focus would be on oral hypoglycemic agents. The speaker is Dr. Nikhil Tandon. And with this, we'd like to close this webinar. Do you have any feedback? Please feel free to share with us. And if you have any suggestion with regard to our forthcoming webinars, because every month we have spoken that we'll be coming up with a webinar. So if you have any suggestion with regard to that, feel free to share with us. This brings us to the end, and BMJ team is signing off. Thank you and have a good day ahead. Thank you.
Thank you.